Welcome back to the deep dive. We're here to take on complex topics, look at all the sources, and give you the essential knowledge, but, without the jargon. Today, we're doing a deep dive into something incredibly common, a procedure called laparoscopic cholecystectomy.
Which is really just the medical term for gallbladder removal.
Exactly. And if you're facing this, or just curious, our mission is simple. We want to turn this clinical subject into a clear roadmap for you. We'll cover the why, the how, and most importantly, what recovery actually looks like.
And a good roadmap starts at the beginning. So before we even talk about removing it, what is the gallbladder?
Right. What does it do?
Think of it as a small, pear-shaped organ. It's tucked right under your liver on the upper right side of your abdomen.
It's pretty small, but I assume it has a big job, or else why would it be there?
It does, but it's a simple one. Your liver is always making something called bile, which you need to digest fats. Instead of that bile just dripping down all the time, it goes to the gallbladder to be stored.
Yeah.
And concentrated. So when you eat, say, a fatty meal, the gallbladder gives a little squeeze.
And sends that concentrated bile out to help with digestion.
Precisely.
Okay, so let's tackle the biggest question right away, the one that I imagine causes the most anxiety. If you take out that storage unit, does digestion just break?
That is the crucial point, and it's actually very reassuring. The answer is no. Digestion doesn't break down.
Because the liver is still working.
Exactly. The liver, the factory making the bile, is completely untouched. It keeps doing its job. After surgery, the bile just flows directly into the small intestine as it's made, instead of being stored first.
So there's no interruption to the supply, just the delivery method.
That's right. And the vast majority of people digest food completely normally afterwards. We can talk about some temporary adjustments later, but the core function is maintained.
That is vital context. So let's move on. Section 1. Why does this surgery become, necessary? We hear about gallstones all the time, but are they always the culprit?
They are almost always the primary trigger, yes.
Yeah.
They start a kind of domino effect. We do the surgery for the stones themselves, but also for what they cause.
Yeah.
Things like inflammation, which we call cholecystitis.
And that's just the gallbladder getting infected or irritated?
Yes, either chronically over time or as a sudden acute attack. We also look for things like polyps or other growths. The real need for surgery comes when those stones cause repeated, severe attacks of pain, usually after meals.
But the real emergency is when a stone escapes, right?
That's when things get very serious. If a stone moves and blocks one of the bile ducts, it can cause jaundice, or even worse, it can lead to pancreatitis.
Inflammation of the pancreas.
Which can be life-threatening, yes.
So let's talk about the calculation. Someone might have an ultrasound and find out they have stones, but they're asymptomatic. They don't hurt. It's so tempting to just watch and wait.
It is tempting. But the data shows that's a very high-stakes gamble.
What are the numbers? What does high stakes actually mean for someone choosing to wait?
Okay, so the most common thing that will happen is you'll develop those painful attacks, what we call biliary colic. The risk of that happening over time is somewhere between 60 and 70%.
60 to 70. So you're betting against a 2/3 chance of future debilitating pain.
You are, and that's just the pain. Then you get into the more dangerous complications.
Like the infection you mentioned.
Right. Acute cholecystitis, a sudden and severe infection, has a 20 to 30% risk over time.
Wow.
And pancreatitis, that inflammation of the pancreas, carries a 5 to 10% risk. And we need to pause on that number.
1 in 10 people who wait could end up with a life-threatening complication.
Potentially.
Yes.
Up to 1 in 10. So waiting isn't really a passive choice. It's an active choice to accept a pretty significant statistical risk.
That really reframes the decision.
It does. And then you have bile duct blockage, jaundice. That's another 5 to 8% of patients. And though it's very rare, less than 1%, we know that long-standing stones do slightly increase the risk of gallbladder cancer.
So the disease really doesn't tend to fix itself.
It almost never does. It tends to progress.
Which makes a strong case for being proactive. So let's talk about alternatives. I'm sure people ask you all the time about medication or that shockwave therapy. Why aren't those the gold standard?
It's a great question, and we go through it with every patient. The simple answer is that they don't offer a permanent solution.
How so?
Well, they only treat the symptom, the stones, but not the organ that's making them. Take the medication, for instance. It's called ursodeoxycholic acid.
Okay.
It can dissolve very small cholesterol stones, but the success rate is low, maybe less than 20%. And even if it works, the recurrence rate once you stop the medicine is around 80%.
80%, so the problem just comes right back.
Yeah, almost always comes right back. Because the gallbladder's still there, still making them.
And what about the shockwave lithotripsy?
It's a similar story. It's a bit more successful initially, maybe 40 to 50% of the time it breaks up the stones. But again, about half of those patients, 50 to 60%, just form new stones later.
What about the endoscopic procedure, ERCP? We hear that's very successful.
It is over 90% successful. But it has a very specific job. ERCP only removes stones that have already escaped the gallbladder and gotten stuck in the bile ducts.
Ah, I see. So it's an emergency fix for a blockage.
Exactly. It can't get inside the gallbladder itself to remove the stones that are still in there, waiting to cause the next problem.
So you've just cleaned out the drain pipe, but the stone factory is still open for business.
That's the perfect way to describe it. And that's why, when you look at all the data, laparoscopic surgery is the only permanent cure. It removes the source of the problem.
Okay, let's move to section 3. Walk us through the procedure itself. What does minimally invasive actually mean for the patient?
It's a huge difference from older surgeries. It means we avoid making one large, painful incision that has to cut through muscle. Instead, this is done under general anesthesia, and we use usually 4 very small cuts.
And when you say small, what are we talking about?
About a centimeter or less, maybe 5 to 10 millimeters. Through one of those, we insert the laparoscope.
The little camera.
The little camera, yes. It gives us a magnified, high-definition view of everything on a monitor. Then, through the other small ports, we use specialized instruments to carefully separate and remove the gallbladder.
That mental picture is really helpful. How long does an operation like this usually take?
It's pretty quick. Typically, it lasts somewhere between 45 and 90 minutes. And that combination, small incisions, short operating time, is what leads to such a fast recovery.
Less trauma to the body means a quicker bounce back.
A much quicker bounce back. And it's important to remember, any bloating you might feel right after is usually just from the gas we use to inflate the abdomen for a clear view. It's temporary. It is not a sign that something went wrong.
Okay, let's build that recovery roadmap. Section 4. What does a listener need to do to prepare in the days before the surgery?
Preparation is really key. In the days leading up, you'll have some routine blood tests and probably another ultrasound. It's also vital to have any chronic conditions like diabetes or high blood pressure under tight control.
And medication.
Yes, your surgeon will give you specific instructions, especially if you're on blood thinners. It's critical to follow those exactly.
Anything to do the night before?
Just a couple of simple but important things. You'll need to fast, so no food or drink, for about 8 hours before. And we always recommend a really thorough shower, paying special attention to cleaning the belly button area. It helps reduce infection risk.
Got it. Now, the big one.
Yeah.
The first 24 hours after. What will you feel and what should you be doing?
You should expect some mild to moderate pain, but that's very well controlled with medication. The most important thing, though, is movement.
Really? That soon?
Absolutely. We encourage patients to be up and walking within 4 to 6 hours after the procedure. It's crucial for preventing complications. And you'll likely be allowed to have clear liquids pretty soon after you wake up.
What does that mean for the hospital stay?
It's usually very short, after about 1 to 3 hours in the recovery room. Most patients only stay in the hospital for 1 day. Some healthy patients even go home the same day.
Wow. Okay, so now you're home, the first week. What's the timeline for getting back to normal life?
It accelerates pretty quickly. You can resume light activity, walking around, making a sandwich after just a day or two. You'll want to gradually ease back into a normal diet, maybe starting with less fatty foods.
And work, driving.
If you have a desk job, you can often be back to work in about a week. For driving, the rule is you can usually drive after 24 hours, but only if you're completely off any strong narcotic painkillers.
What about the longer-term limits, like hitting the gym or lifting something heavy?
That's the main restriction. We advise avoiding any heavy lifting or strenuous exercise for about 4 weeks. That gives those small internal incision sites time to heal properly and reduces the risk of a hernia.
And let's revisit digestion. You said some people have temporary changes.
Yes, and it's important to know this is normal and temporary. Maybe 10 to 20% of people might have some bloating, and maybe 5 to 10% notice looser stools, especially after a very fatty meal.
But it gets better.
It almost always gets better within a few weeks to a few months. It's just your body adapting, it's manageable, and it's not dangerous.
This brings us to our final section, Section 5, safety. For someone at home recovering, how do you tell the difference between normal aches and a real red flag?
This is so important. We want you to be watchful, not worried. The red flags are usually things that are getting rapidly worse, not better.
Okay, so what's on the emergency list?
You need to call your doctor or go to the ER if you develop a fever over 38 degrees Celsius which is about 100.4 Fahrenheit. Also, severe abdominal pain that is worsening or significant swelling. And any sign of jaundice, so a yellowing of your skin or the whites of your eyes.
What about eating and drinking?
If you're vomiting persistently or you just can't keep any liquids down, that's another reason to call. And you have to watch the incisions.
Looking for infection.
Exactly. Any blood or pus, or if the site becomes increasingly red, warm, or painful. And finally, of course, any difficulty breathing or chest pain is an immediate emergency.
And just for full transparency, while this is a very safe procedure, what are the actual rates of some of those complications?
Of course, the overall safety record is excellent. Significant bleeding is rare, maybe 1 to 2% of cases. A wound infection happens in about 1 to 3%.
And the one people worry about most, a major injury to the bile duct.
That is exceedingly rare. It occurs in only about 0.2 to 0.5% of procedures. I mean, this surgery is done successfully thousands of times every single day.
So when we wrap this all up, what's the big takeaway from our deep dive today?
The message is honestly one of profound reassurance. Gallbladder removal is one of the safest and most successful operations we do. It's a permanent fix for a problem that can otherwise cause years of pain and serious risk.
And the recovery is fast, getting people back to their lives.
Incredibly fast. Most people feel better within days and are completely free from that gallbladder pain forever.
A really clear and positive outlook. But we'll leave you, the listener, with one final thought to consider. Even after a perfectly successful surgery, why do about 5 to 10% of patients still experience some persistent pain in that same area? It's a condition known as post-cholecystectomy syndrome. Sometimes it's from a tiny stone that was missed, or maybe a spasm in the remaining bile duct. It's just a final reminder that the body is a complex system, and its adaptive process is, well, it's a story all its own.